All right. And we covered 11 papers. So thank you all the presenters for preparing these videos. I think we all agree these were excellent. And I've compiled a number of questions that we can discuss over the next half hour that we have. By the way, I was so eager to get started that I even forgot to introduce myself. So my name is Edison Tomas from the University of Texas at Austin. So I'm sure that many of you already know me, but anyways, so I think what I'd like to do is I'd like to start in order. So there are a few different questions that are specific to the papers, and then there are some other questions that we can ask that are a little bit more high level. So starting with the very first paper, there were a couple of questions that were pretty popular. So, so this was about detecting breaks at work. So one of the questions was, which sensors prove to be more useful, and which features also prove to be more useful. So can you provide a little bit more details on that?
Sure. Thank you for the question, which I think it's a very interesting question, because it's true that if from one side we use multiple sensors to have a richer representation of people behavior and context, on the other side we need to be careful and not overwhelm the users with multiple devices. So what we did in this direction, first of all, was to use personal devices for collecting, for gathering sensor data. So to not ask participants or in general future users to carry additional devices that they wouldn't use in their life. So in this case, we use a wristband, a laptop, and a phone that are all devices that people usually carry with them. Said that, then we analyze the impact of the different sensors and the different features. So we study the combination of the sensors and so on. So first thing we noticed is that when we were using a single source of information, so only a single device, only the laptop, only the phone, only the wristband, then the performance were lower. So the best results are obtained when we use all the devices, so the wristband, the laptop, and the phone all together, but except the BVP sensor. So in this case, it was not having a high impact. Then what we notice also is that, for example, if we use the phone data in this group of devices, it doesn't have a very strong impact, in the sense we only have a 2% improvement on the performance. So for example, in a system, in a phylon system, the user might accept this smaller reduction in terms of performance, but not monitor the phone, for example. This is because the phone has a very peculiar role in the workplace. For example, that are people that use it a lot also for working purposes, for example, for talking to their colleagues and so on. And there are people that don't use it at all. So the phone is still something that it's particular in the work environment. Then for the other sensors, we noticed that the accelerometer has a good, was having a strong impact, and that's because we spend most of the time sitting. So when we move, this could be a good hint for break. And also the physiological activation in terms, especially of the phasic component of the ectodermal activity, which again, for example, during breaks, we tend to have more interaction, so higher physiological activation, and then again could be a good hint for the arousal and then for the breaks.
Great, thank you. So these were knowledge workers. So most of the time, were they sitting down working on a computer? Is that what you observed?
So basically, we didn't put any restrictions in these terms. So we just ask workers to work normally. So for example, we have instances ranging from 6 a.m. to 11 p.m. But also we didn't collect the location. So exactly, we don't know where the user is. But we know from also talking for our participant that some instances were at home, some were in office, when it was in the train. So it was a bit, there's a mix of activities in there.
Great, thank you. Thank you for answering this question. All right, let's move on to the next one. So I have also at least one question on the freehand sketches for potential screening of PTSD. So here, one of the questions was also related to the features. So which features were most useful in that type of screening? And I would also add that I'm familiar with, for example, the clock drawing test, which is used for cognitive impairment, I believe Alzheimer's screening. And so I was just wondering if you could also talk about maybe differences between your approach and some of these other techniques that exist.
For example, in our study, we requested our participants to prepare two different sketches, the sketches of their past home for the Rohingya refugees, and for the other two groups, the slum dwellers and the engineering students, we requested them to sketch their present homes. Besides, we requested all our participants to sketch their expected future homes. When we analyzed statistically, we found that average length of strokes and the number of strokes in both of these types of sketches differ significantly in the sketches of the patients who were participants who were potentially screened with PTSD versus those who were not. So when we developed our logistic regression models, we observed that the average length of strokes and the number of strokes, they had significant effect in predicting PTSD. And the participants were potentially screened with PTSD in their sketches. Both of these features were significantly less in numbers compared to the participants who were not screened with PTSD. So to establish our ground truth, we used a PTSD screening tool, which was specifically designed for psychiatric emergency settings, for example, the refugees or other types of populations. So that was the basic approach. We conducted a semi-structured interview sessions with our participants. And for the engineering students, we actually used a self-reported screening tool. So that's how we set our ground truth.
Okay, great, very good. Thank you so much. This is great work, and I really like that this is targeting a different population that we usually see in many of the work that that's featured at UbiComp. So, so this is terrific, and also really nice to see the contribution of so many of you from Bangladesh in this work. So that's wonderful to see. Okay. So the next question I'm going to ask is about the related to the smoking up paper. And one point that was brought up was that in some places around the world, there's no regulation around where people can smoke. And so basically you can have people smoking anywhere inside their homes and so on. And so the question was, how would your system operate, or how well would it operate in a scenario where location is not such a powerful feature in screening agents, opportunity contexts?
Right. So that's a great question, actually, and I would like to let you know that this work has been done on the data collected from participants in the city of Houston. And in general, in these cities, the cigarette sales are pretty well regulated. So, for example, cigarettes are usually sold at licensed gasoline or retail stores. So that's why, one assumption is that there has to be some regulation in the sales of cigarettes. But our approach may not work in places which is where the cigarette sale is not much regulated. So it would be really interesting to explore how to capture the smoking opportunity contexts where the cigarette sales are not much regulated. And for the question that pertained to cigarette smoking at homes, so that location would be actually captured in the personal smoking spots. So if the model finds that someone usually smokes in and around their home, then that would be captured as one of their personal smoking spots, and then it would be incorporated in the smoking model.
I see.
Yeah.
And I noticed in your slides when you were talking about adverse behaviors that suicide attempts and binge eating and things like that. It seems like the detection of opportunity contexts, which you define basically just a changing of location and changing of activity state. It seems like this system, this general idea that you have, would be able to sort of generalize to other adverse behaviors as well, right? So this work is focused on smoking, but it seems like you could potentially generalize this to other behaviors, given how generically you describe it, change of location.
Right.
So can you
Right.
talk a little bit about what the differences would be, I guess, if you were trying to use the same type of approach or to detect other kinds of adverse behaviors?
Sure. So, for example, for binge eating, so there is this locations of interest, right? For smoking, it's a cigarette point of sale, or your like home, or then you are going to a bar and where you can like smokes are easily available. For eating or for even for binge drinking, so these kind of locations of interest would change. But the modeling approach can be adapted to some extent, but then the data collection has to be different, and the space of interest has to be different, and maybe there can be more like direct measures. So we are so for example, when we are going from indoor to outdoor, that creates a smoking opportunity context, but for eating or for binge eating, indoors are more favorable. So that kind of approaches need to be thought more carefully before modeling those for those adverse behaviors.
Right. And so when you're looking at location, are you looking at specific locations or are you looking at transitions between locations?
Both. So
the temporal component of the movement.
Right. So actually, so first first we are trying to identify those spots where people usually smokes or can see other smoking. So once we have done that, then when we are creating this windows, and that is these are the temporal sequences of windows. Those actually capture the transitions through these states as well. So that's how it is being incorporated in this model.
Very good. All right. Thank you so much.
Yeah. Thank you.
Yes. Lots of questions about the sleeping posture body compass paper. And I will start that questions about this paper with one that occurred to me, which is what about if you have more than one person sleeping on the bed? Have you tested under that particular scenario? Not only people, but pets also, right? You could have pets sleeping in beds. So.
Yeah, so I think that's one of our current limitations. So all our experiments are collected with only one person sleeping in the bed, but we do have our previous work that can extract multiple persons' breathing signals in the wild. So ideally, we can separate those two people's breathing signals and filter out each person's contribution and do the same thing. But you're gonna certainly put some challenges because those breathings will mix together. So I would say it's doable, but it's still one step ahead of what we currently have.
I see. Can you talk a little bit more about how you obtained your ground truth for the data in this case?
Yeah, so we put accelerometers on a human body, one on the chest and one on the belly. So we used to mutual verify each other because sometimes the accelerometer may drop off during the sleep. So we use the accelerometer to put two of those accelerometers on the body, and we extract the angle from the accelerometers. We directly using sport tape to tape it on the body, because if you put it on the shirt, it will move during the night. So we directly tape it on the body to make sure the data is clean.
I see. Is there any reason why you chose not to have, I guess, a camera just for this particular data collection?
Camera is so if you use cameras, you can only see a head, but like with that head, it doesn't necessarily mean where their posture is facing to. Like with a camera facing on the head, you can't tell whether they are sleeping upwards or sleeping facing to the right, because it looks identically. And also, if you're highly privacy intrusive, we don't want to go along that path. Also, we don't have IRB for that, so we choose to use accelerometers, and it's very reliable in the end.
Okay, very good, very good. Thank you. I will check if there are any other questions here for you, and maybe I'll come back. Thank you. Great work, by the way. This is good. Is there? By the way, let me ask you just another question. So I saw in one of the photos that the sensor is actually on the wall.
Yes.
Right, next to the. Is there any sensitivity to where that sensor is placed, and whether you can make it a little bit smaller?
Yeah. Actually, this is a very good question. So we do actually do some experiments about the location. So because our system works, we usually require it to put on the side of the wall. So either on the left side or the right side, because that's where the most high quality signals are coming from. Because you need to sleeping facing to the device. So if you put the facing your feet, you cannot get very good reflections. So you need to be on the side of the wall. But there are some flexibilities there. If you put slightly further away, slightly near, we have such domain adaptation techniques to encounter all of that. And we also put it on the slightly shifted. It's not required to be directly facing to the chest. They are allowing like 1 meter or 2 meter errors. That's addressable, but not too much. So there's a comfortable zone in that we can achieve the highest quality of signal.
Very good. And have you looked at how your system compares to those sensors that you place underneath the mattress, for example?
We don't have access to those techniques, so we can't directly compare to them. But yeah, so but nevertheless, you need to change the mattress, which is really hard to do.
Sure. Yeah. Thank you.
Thanks.
Great. All right. Now I would like to move on to the fatigue detection paper. And for this one, I would love to just hear a little bit more just about the data, about how the data was collected and so on.
Okay. Well, we collect data. It's like a very, like a pilot study for a big project. We collect 13 subjects, but none of them stayed available. And we collect accelerometer data and also ECG data via vital patch. And the label are like questionnaires, fatigue level from 0 to 10. And we ask them in the morning, at night, at noon, so like 4 times a day, every 6 hours. So it's very subjective. The label is very subjective.
Nice.
Yeah, so but we try to, like build this kind of system, can continuously monitor it. So like that's why we use the sensing. And we collect the data and we build 2 solutions. One interpretable solution focused on feature engineering, and the other one is deep learning solution. Not black box, but better result. And the motivation we developed both algorithm is deep learning can give up like what's the upper bound of both modalities, and in the future we probably can use this to guide how to do feature engineering. As you can see, we combine 3 interpretable solution, which is traditional feature selection, traditional machine learning, and the combining effect is not that great. But deep learning solution tell us, the combining result could be much better. So we should do more feature engineering in the like accelerometer part. Yeah. Well, maybe I talk too much. That's not just like how to collect data, but how to,
No, this is great.
The whole pipeline, yeah.
No, this is great. No, thank you. Thank you so much. I will actually build upon this question and maybe ask a question that is open to all the presenters. So now moving beyond just questions from individual papers to me talking a little bit more high level. In this work, we rely quite a bit on self-reported data and questionnaires and surveys and so on. And we all know the weaknesses of these types of approaches. But we are using self-reported data essentially as ground truth to guide the development of mobile health-based systems. And so are we basically just cascading the problem down to now our mobile health systems if our ground truth is based on self-reported methods? What are your thoughts? And maybe I'll open up to others as well if anybody would like to chime in. You maybe do you wanna start? Just
well, okay, I can start. Well, I mean, yesterday, the keynote, it's quite important. It's like the emotion. Emotion is very subjective. And also, but there are lots of useful feedbacks. Some other people can observe your emotion. I mean, for us, for our case, fatigue is even harder. And I have to say, fatigue in our case is not tiredness. It's like kind of fatigue caused by disease. You know, some people just sleep all day and still feel fatigue. So it's you know, like a self-report. That's really hard. But in machine learning, that's a topic named like a noisy label problem. You know, we hope maybe, you know, like when the data is much larger, maybe, you know, the machine can learn from the population. And yesterday I heard two solutions. One is keep human in the loop. I think that's a good idea. You know, like machine give you a prediction and interact with the subject. Subject is just like, is that right or not? And gradually the machine learn your pattern. Another thing is like develop the personalized method, you know, like, well, those kind of ideas, you know, like the subject questionnaires. Well, you know, I asked the clinician, what's your gold standard? He said, well, you know, measure questionnaire, you know, fatigue. According to the definition of fatigue, it's very subjective. Right. You know, what I'm saying is physical fatigue, not mental fatigue. Mental fatigue, you got other measurement. But, you know, like, you know, they say that's what they measure. But, you know, there's, well, you know, and we try to explore how to use like, you know, at least we can solve the continuous monitoring, because the questionnaire maybe after like, you know, 24 hours you forgot, but at least this can give you like in time some result. At least, well, maybe in the future we develop an app and the result can just like interact with people. People just like, you know, confirm, yeah, is that right or not? You know, yeah, because
this question is somewhat inspired by one talk that I followed yesterday, which was by a team from Dartmouth on predicting brain functional connectivity using mobile sensing, where they are actually trying to come up with an objective measure of what's actually happening inside the brain to be able to get to some of these measures that are, you know, have been historically difficult for us to just obtain using a sensor on the wrist, for example, like emotions and so on. So anyways, thank you. Anybody else would like to chime in on this?
So one thought I had, also hi, my name is Sanjana. Yeah. And so one thought I had in terms of objectively measuring these kinds of metrics is ultimately like our objective metric might create like measure multiple dimensions that clinically a doctor might see and say, oh, that means something to me. But when we want to think about these systems playing a role directly in like patients' lives and not having to go through a clinician first, I feel like sometimes the numbers don't necessarily add up to the lived experience of that person, kind of like you was saying, in terms of someone could be sleeping all day and maybe like their body is measured, if you objectively measure it, it's fully well rested, but they still have some perceived fatigue. So I guess my thought on self-report is kind of going off of his comment that keeping the human in the loop is really important, is we can come up with objective measurements to help our systems maybe not be as heavily dependent on self-report, but I feel like having the human there to provide some feedback as to how accurate the measures that we actually are looking at coincide with their perceived experience, because I think ultimately that's what we're targeting, because we already have like EKG machines and things that can spit numbers at clinicians and the clinicians can interpret that, but that's just a thought.
Very good, very good. And thanks for bringing your cat to the session, making a cameo appearance. No, I mean, these are obviously difficult questions, and there's no right answer, right? We're always trying to improve the way we do things. But these are good questions to be thinking about and asking. This point about bringing data and systems back to clinicians, getting them into the loop is another topic that is often in our work present in the community. And so again, another question that I'm opening up for everyone is, when you are building your systems and you are starting to evaluate your models and you're starting to get your performance results, somewhat of a cliche question as well, but when do you decide that it's enough to essentially stop optimizing your approach and say, okay, this is good enough now. It's time now to think about how we can take the next leap forward. We've reached a point where we find that the system is working well enough now. How do you determine that point? Is it heuristically based? Is it based on a rule of thumb? Oh, 85%, you know, this is good enough. Is it based on some clinical measure that you're after? What's been the driving direction here, or the driving force behind your approaches for, or your decision to stop your analysis?
Maybe I can respond. Hello.
Hi.
Hello. Yeah, I think that's a very good question. You know, ideally, we want to evaluate our models with totally different new populations. Then we want to verify the generalizability, and I think that kind of activity is started already little by little. Then depending on the application, it can be clinical or non-clinical. Then I think we have a different like goal to achieve. So I'm not sure. I might not be answering the question fully. But...
No, I think this is good. This is, I think, an important point, that whether you have an application that is aimed at clinicians versus one that's not aimed at clinicians. For example, our first paper was on detecting breaks. This would be more in the realm of personal informatics, is just for an individual to gain more self-knowledge about when it's a good time to maybe perform some tests or not. But when you have some clinical use case, then it becomes more challenging. Perhaps you need to match the performance of some medically validated device or instrument or survey.
Mm-hmm.
Thank you. Anybody else would like to try to tackle this question?
It's me again, sorry. Okay. We work together with other clinicians on medical cases. Well, to them, they always use some medical validated features, and they trust like simple models like a linear regression. And to us, because if we have the raw data, we try to develop machine learning to learn new features, maybe not interpretable, but if we can combine together better than their standard, which is the clinically relevant feature plus the linear model, and which we sacrifice a bit interpretability, but with some performance. And also we also try to see whether it generalizes to new people, new subjects. So that's our standard. It should be better. We hope much better than the standard algorithm, because use data-driven approach, we try to discover any new feature that never discovered by clinician before, but which we think and we try to interpret.
All right, very good. Thank you, Yu.
No problem.
Anybody else?
Yeah, I can add a little bit. So I think this is a really good question. So it also bothered me a lot. So last time we are crazy tuning the performance to a point we are satisfactory. So first, my advisor need to be happy about it, and then to be compared with related work. And also a big problem about our work is we use slightly different metrics than our peers' work. So we are measuring angles. So so finally, we are to a point, putting another month will not increase even 1%. Then we are stopped there. So it's just a tuning and trying and finally giving up process.
Right. Yes, that's often how it goes. Very good. Well, I see that it's almost 10:30, so I'm going to be stopping now because I know you have other sessions that you'd like to attend, and maybe it's now time to stand up, take a break. You can see here behind my window, the sun is shining outside. Maybe you can go walk outside and check the temperature of the water, or maybe next year, right? But joking aside, thank you so much for joining this session. I think this was terrific. We had some great papers. Hopefully, the topics and questions that I picked here were some of the ones that piqued your interest and were interesting to you. So I will see you around, and I don't have the schedule here in front of me at the moment, but you know, you can open up Hova and see what's coming up next. So thank you again for coming, and thank you all the presenters for their videos, and I will see you around the conference.
Just to add on to what Edison said about the schedule. So we have the ISWC design panel that's coming up after a short break. And then one thing I actually want to highlight to everyone is that in GatherTown, we have set up some discussion rooms where people can, you know, authors can go to this room, and if you still have other questions, you can go and talk to the authors face to face. So we encourage everyone to go to GatherTown if you have other questions. And of course, we have other things in Hoover. So many ways you can ask questions. So don't be afraid to engage with the authors, and authors, don't be afraid to answer.
Great.
Thanks, everyone.
Thank you, Alex. Yes. All right. Thank you all.
Thank you. Bye.